I am George Jacob, and I'm a surgeon. I work down in Kochi, which is a small city in Kerala, South India. So I think early on for me, we started using polytapes, and we started using them especially for our patella tendon and quadricep ruptures. So any extensor mechanism injury, especially the really bad ones that you get after a knee replacement, which really take away the confidence from the patient and the surgeon. I think with a polytape, we found that it just improved their rehab so much, and we've been using them for about 7 years. Our longest follow-up that we have is about 7 years. We've got MRI data as well. We've seen excellent results. And we're continuing to use it for patients, and we continue to do pre-op and post-op MRIs at different time points, and we're following them up, and I can say the recovery is immense. They don't go backwards, they continue to go forwards in their recovery after a replacement, even after a sports injury. The really bad ones where they do have extensor mechanism injuries, again, it's just a game changer. So I really do believe that they have a very important role to play. Again, a really important thing for me is that even the exposure when you're doing an extensor mechanism reconstruction is so much less. You can work with much smaller incisions. A lot of it is percutaneous. You can shuttle under the skin. It's just so much better for the patient. So there's a lot of technique available on the website, and we've got a few videos that we've put out there as well. It's simple surgery. Anyone can do it. So I think it's just really worth having. We see our patients standard after the rehab, and at 2 weeks, during suture removal, I had a patient who had come to visit me from the Middle East, and I think what really shook me, and it's not even my belief in the implant, was the patient just stood up and kicked his knee straight, and I said, "Don't do that," and he said, "I'm fine, I'm good," and we hadn't even taken his stitches out yet, and that's what really gave me the confidence. And I was just talking to my fellow colleagues, and I was saying it was actually a patient that could feel the difference in his knee, and he actually showed me that he was doing well. We collect ROM scores, and we look at our KU scores, and we look at their IKDC scores, and they've all done consistently well. So even the older age groups, they're all doing very well. So I'm very happy, and it makes it makes a very difficult surgery into a very simple surgery, and I think it's well worth having it as your first choice. I think it's basically strength on day one. I think the synthetic gives the patient confidence and strength on day one, and it's also instilled a lot of confidence in me, which means rehab is much faster. We can catch them up much quicker and get them moving much faster. So I think that's really where it comes from. And I've been using it also for my multi-ligaments. And when you have a dearth of, when you haven't got enough graft, it's definitely a lifesaver. You don't need to go and harvest all of their tendons, and then in my practice, I truly don't like using allograft, so it's always an autograft. But now with the synthetics, I've definitely reaching out for them more often, and I've been using them for my MCLs when they're indicated, for my posterolateral corners as well. And I think they really are a game changer for those sort of injuries. So a normal autograft kind of has to undergo apoptosis, and it's at its weakest point at 6 weeks. And someone who's 6 weeks after surgery, you expect them to continue to get stronger, but actually it's the other way around. The graft's actually at its weakest point at 6 weeks, and it's from 6 weeks that we start to see the ligamentization process, and that's why we have rehab that's prescribed to slowly get that graft to ligamentize and become similar to what the ACL used to be. With a synthetic ligament, you've got strength on day one, so I think that's really going to affect the way that we can actually get this patient back. So that's going to be a really important factor. We still have graft site morbidity. I think it's really important to know that a lot of us have moved away from hamstring tendons. A lot of us have moved to quads. Some of us are looking at peroneus. We've got data to suggest at 2 years, your hamstring is still not the same as the opposite side, and that's really made me think about whether I want to take something that is an anterior restraint for the tibia and works, alongside the ACL. Why would I sacrifice that graft? So I think we really are at a position where we need to start thinking about, do we have other options? And I think, I know the synthetics have had some bad experiences, and I think there's lots and lots of reasons for that, but I think it's time to really be open to the fact that we are evolving and learning more and more, and I think it would be a huge step forward if we didn't have to use an autograft, and if we had something on the shelf that could just bring a patient back to full function much faster, especially since we've got lots of sports happening, and there's a huge economic advantage to the athlete if they can get back to sports faster.